all the panel of experts and everyone. So first of all, I would like to thank you, Bangladesh Society of Breast Cancer Study and Dr. Das for inviting me to share the experience and give a little bit of a talk today. So the topic that I'm going to give a talk is about guiding decision to omit radiation after breast conserving surgery. So I'm going to cover DCIS and also invasive. So let's get started with omission in DCIS. All right, so these are for landmark randomized trials comparing radiation and without radiation after breast conserving surgery in DCIS. And you know all about these studies, ABPB17, EORTC, Swedish trial, and UK, Australia, New Zealand study. So radiation techniques, 50 gray in 25 fractions, and also some studies include hyperfractions treatment as well. So adjuvant radiation approximately half the rate of ipsilateral breast events and also can reduce the absolute 10-year risk of any ipsilateral breast event by 15%, both in recurrent of DCIS and invasive. But how about low-risk DCIS? So these are 4 studies that study in low-risk DCIS. Ontario trial from Canada, 2013, Boston trial, ECOG and RTOG from Memorial Sloan Kettering Cancer Center. So Boston trial, so in this trial, low-risk DCIS defined by mammogram detected, less than 2.5 centimeter, low to intermediate grade, and the margin is more than 1 centimeter. And you can see that incidence of local recurrence was about 1.5% per year. And the invasive and DCIS recurrence rate was about 50 and 50. So this is from Boston trial. From ECOG, there are 2 groups of patients, low intermediate group and high grade group. So in the first group, low to intermediate group, tumor size no more than 2.5 centimeter and the margin is 3 millimeters, while the high grade group, tumor no more than 1 centimeter and the same margin. So again, the event rates of ipsilateral breast events was about 1.5% each year, while rose to 2.5% per year for the high-grade group. How about in Ontario study from Canada? So this trial studied over 3,000 women. So there are 2 arms, one arm without radiation and the other arm breast conserving surgery with adjuvant radiation. And you can see that having radiation after breast conserving surgery had higher local recurrence free survival rates. But out of 3,000 patients in this study, only 700 patients defined with low-risk DCIS, which were aged more than 50 years old, unifocal DCIS, low to intermediate grade, and negative margins. So this study defined positive margin if there were tumor cells identified at the resection margin. So from this study, they conclude that without radiation resulted in substantive recurrence. How about RTOG? This is the famous study from Memorial Sloan Kettering Cancer Center. So again, the good risk in this study defined as mammogram detected, low to intermediate grade, tumor size less than 2.5, and the margins more than 3 millimeters, and tamoxifen is optional. At ASTRO 2018, that was 12-year updated data. And you can see that whole breast radiation significantly reduced local recurrence and invasive local recurrence in good risk DCIS. And again, no significant in survival, disease-free survival, and mastectomy use. So this is MSKCC nomogram. So it's Memorial Sloan Kettering Cancer Center nomogram. So it's one of the prediction tools available on the website. And there are 10 clinical, pathologic, and treatment variables that were built into this nomogram to estimate the probability of 5 and 10-year ipsilateral breast tumor recurrence. And the factors that we think that it influence local recurrence are this that put into the nomogram: using radiation or not, having hormonal treatment, age, margin, number of excisions, and the time period of treatment. So this is, you can just Google it and you find it, the nomogram here, and then you just enter the information of the patients, and the results are on the right side. So it's gonna come out probability of recurrence at 5 years and 10 years. So on the website, patients can do it by themselves, and the website suggested to use this information and talk with the doctors. So all in all, from those studies, so these are clinical pathological features to predict local recurrence risk of the breast conserving surgery: age, tumor size, nuclear grade, comedonal necrosis, unifocal or multifocal DCIS, and the margins, and clinical presentations at the beginning. Biomarker. So do we think biomarker is going to benefit in treatment decision, neoradiation or radiation? So we think that biomarkers would be benefit if it can improve the accuracy of the predicted risk of local recurrence of the breast conserving surgery, or if it can identify a subgroup with 10-year local recurrence risk less than 10% of the breast conserving surgery. So normally, so this is multi-gene expression assays, Oncotype DX recurrence score 21, that is used in invasive breast cancer. But for DCIS, they use DCIS score 12, which compose of 7 cancer-related genes here and 5 references genes. The report, so it's going to report 10-year risk of any ipsilateral breast events of the breast conserving surgery. If the score is less than 39, it means low risk. The score 39 to 54, intermediate risk, and more than 55, high risk. And with the score this is low, it might be possible if we could omit radiation. So there are 2 studies to validate this Oncotype DCIS score. ECOG study and Ontario DCIS study, and they found that DCIS score is valid in population of women with DCIS. So you can see that the low risk group, the blue line here, appears to have a lower risk of local recurrence than those in intermediate or high risk group, and they did observe a significant decrease in the rate of local recurrence over time. So the factors that are associated with local recurrence of the breast conserving surgery from the validation study, and you know that age, tumor size, focal, and the margins are associated. But other one character that associated as well is a DCIS score. So how the Oncotype DX can change radiation practice? So this is the study from Rakovich, and the study in 200 DCIS patients, and the outcome is change in radiation recommendation by physician. And they found that Oncotype DX score can change in treatment decision from 79% pre-ADSAID to 50% post-ADSAID. And Rakovich has compared the models to predict local recurrence. So there are 3 lines here: gray, purple, and blue. With the gray, they use only tumor size and age. With the purple, they use DCI score alone, and the blue lines, they use both. So this study, the author found that the best predictive models for local recurrence was the combination of using DCI score and clinical pathological features, because with the combination models, it's better to identify high risk and low risk local recurrence. So for conclusion, for omission in DCIS, radiation could be omitted in selected patients. Clinical pathological features are really important to identify the risk of local recurrence, and molecular assays can improve radiation decision from the studies of validating Oncotype DX DCIS. So let's move to invasive breast cancer. So as you know, that radiation after breast conserving surgery in invasive breast cancer was significantly improved in recurrence and breast cancer death, both in lymph node positive and lymph node negative patients. Again, these studies try to determine whether there is a benefit for adjuvant radiation in early stage breast cancer. PRIME2 study, CLGB, Austria study, Princess Margaret from Canada, and NSABP B21. So the first two studies, NSABP in Canada, they start the age of the patients from 50 years on, T1, T2, margin negative, ER positive. And the 3 lots trials, they include all the patients, 65, median age 66 here in this study, and age more than 70 years on. T1 or no more than 3 centimeters in 0, ER positive. So all in all, adding radiation to tamoxifen significantly reduced the risk of local regional recurrence in women with small lymph node negative and hormone receptor positive. This is the Swedish study, and there are 2 arms, one without radiation and the other one have adjuvant radiation. So the patients were T1, T2, and 0 and 0 with breast conserving surgery. And the study had 15 years of follow-up, and it could not identify any subgroups which could be spared radiation. So it means that radiation, it's important for every subgroup. But the limitation of this study is only patients with lymph node metastasis or T2 and 0 were having systemic treatment, while nowadays patients, the tumor size more than 5 millimeters, they could have been prescribed a systemic treatment. So when we say no radiation to the patients, it's a little bit hard. So this is the study that they want us to consider other factors, such as the compliance rate of endocrine therapy varies among patients, and who are actually old, what age, 50, 60, or 70 years on. Do we have to look at the health status evaluation, or how about the life expectancy? And we have to think about the toxicity of radiation that generally less than when compared to the previous era. So this is the St. Gallen meeting 2019. They were talking about this this topic as well. So for elderly patients with stage 1 ER positive, about 58% of the experts was not prepared to omit radiation. But when the age limit rose to 80 years, the percentage of the expert rose to 62% that would be possible to omit radiation. Gene assays that were developed to quantify the likelihood of disease recurrence in early stage breast cancer, for example, Oncotype DX, MammaPrint, Prosigna. So these are developed for invasive breast cancer. For example, this is from NCCN guidelines, and you can see that Oncotype DX score has found to be useful in predicting the benefits from chemotherapy and who can we safely spare. But the question is, can we apply those gene assays to radiation? So this study investigates the association between recurrence score and risk of local regional recurrence. And they found that the similar association between recurrence score and risk of local regional recurrence. So it might be potential clinical implication to local regional recurrence disease and to going to local control therapy decision. This study include patients with lymph node negative and ER positive. This study, again, from Mamins and SBB28, they focus in the patients who were lymph node positive and ER positive. And again, they found that recurrence score was a statistically significant predictor of local regional recurrence. So on the left side is previously that we used to identify the can guide to radiation decisions, Oncotype DX, or immunohistochemistry. But nowadays, there are more we call radiation-specific signatures from Danish breast cancer group and other things. Some of them identify benefit, some of them identify resistant group of radiation, and some of them identify both in the study. But the limitation of this study is still lacking of external data sets, and we have to wait for longer follow-up. There are ongoing studies to identify the groups of patients to omit radiation by using this kind of tools. IDEA study use Oncotype DX. This is study we call precision study to use Presigna, and this is expert trial use PAM50, Lumina trial, and prime time use immunochemistry. So they try to look at the 5-year ipsilateral breast tumor recurrence in the patients with lymph node negative. This is another ongoing study, MA39 from Canada. So again, same general design from the previous studies, but this study include the patients with 1 to 3 lymph node positive and with low risk of Oncotype DX recurrence score. And again, to look at the ipsilateral breast tumor recurrence. So nomograms that we can, that is available on the website is breast cancer nomogram from MD Anderson Cancer Center that we use to predict benefit of radiation for own patients. So these are other variables that you have to fill, HRAS, tumor size, estrogen receptor status, and nodal status, and then calculate. So conclusion for invasive cancer, that if you want to omit radiation, yes, we can, and we can select in low risk older patients. How about genomic-based signatures are not yet available? I'm talking about the new signatures, but the previous one, Oncotype DX or PAM50, something like that, are now ongoing studies. And that we want to use that to guide radiation decisions. All right, so that's it.